So hello everyone. I'm Mara Ionescu, and I'm happy to host another of our Young ESPGHAN Webinar Series. Today we are going to talk about pediatric polyposis syndromes from genetics to endoscopic management, and we have a special guest. Today we have Professor Tomas Attard. Before starting our webinar, I'm going to start with a short introduction about Young ESPGHAN and what is our committee mission. First of all, is to promote high quality research and training for our young members, to organize different activities for our Young ESPGHAN members, but most important, to represent the interests of young ESPGHAN members within the council and the society. What are some of our educational events? First of all, we have our Young ESPGHAN Mentorship Program, which is a forum to meet and receive support from more senior ESPGHAN members. It has been going on since 2017, and last year we had 12 pairs. Here we have some photos from our previous meetings, and we hope that this year's program is going to be excellent as the previous were. Also, every time during our ESPGHAN annual meeting, we have our Young ESPGHAN Day. Last year, it was, of course, in Helsinki on the 14th of May. We had a very interesting workshop about decoding research, about systematic reviews, meta-analysis, and peer review essentials. Also, we organized a reviewers program, which was completed with some of us receiving a certificate. And last, we had our Young ESPGHAN session, and we had the opportunity to do some immersive painting, and we had loads of fun, as you can see in these pictures. And this year, we are going to have many other surprises and interesting workshops for you, so just please register if you haven't already. Also, last year we had a new session, a new Young ESPGHAN session. We talked about clinical cases, and if you had any interesting cases, you had the opportunity to talk with experts in the field. And this year we are going to have a new session. We are going to walk through some guidelines. So please visit us on Saturday during this annual meeting. Also, during each annual meeting, we have Meet the President meeting. And here we have the former and the present president of ESPGHAN. Regarding our upcoming educational events, regarding the ESPGHAN educational events, you have the Eastern European Summer School coming soon, also training the colonoscopy trainer study day, nutrition summer school, but also you can find more courses on our website. There are so many, so please just register. But who is the Young ESPGHAN committee? We have Anne-Marie, who is our chair. We have Vangelis, who is our secretary. We have Petra, our treasurer. We have Francesca, Pinar, myself, Mara, Jose, and our GK Nutrition and HEPCOM representatives, Giovanna, Harwin, and Beno. Some of us, we are going to be switched and replaced with some new members. So if you're not a member, please join us. You have many benefits as a training member, from subscription to JPGN online, to access to different research grants, awards, and different educational events. So it's a good start if you want to become a better professional. Also, in order to become a member, you need an application form, which you can find on the website. You need your CV and a letter of support from a full member, but not serving in the council. Also, if you want to find out more about ESPGHAN and about Young ESPGHAN, you can also download the ESPGHAN app, and you can follow us on Instagram. Regarding our webinars, we have exciting new topics. We are going to talk about Wilson disease next month, and also about the low food map diet, unlocking relief for IBS in children. And also we have different other topics about emerging therapies in IBD, autoimmune hepatitis, basic and advanced endoscopic techniques, and about ROM5 criteria. So join our upcoming Young ESPGHAN members. So without further ado, I would like to introduce our speaker today, Professor Tomas Attard, who is a professor of pediatrics at the University of Missouri, Kansas City School of Medicine, and a consultant of pediatric gastroenterology at Children's Mercy Kansas City, where he serves as clinical director, director of the Hereditary Gastrointestinal Polyposis Multidisciplinary Clinic, and leads gastrointestinal endoscopy services. Dr. Attard's clinical and research work focuses on hereditary gastrointestinal polyposis syndromes and early onset gastrointestinal cancer risk in children and adolescents. He has contributed extensively to international guidelines, multi-center cohort studies, and translational investigations aimed at improving surveillance, endoscopic management, and long-term outcomes in pediatric patients with inherited cancer predisposition syndromes. His work is reflected in a sustained record of peer-reviewed publications, invited reviews, guideline contributions, and international plenary and invited presentations in pediatric gastroenterology and endoscopy. And it's a great honor for us to have you here today, and we are very thankful for accepting our invitation.
Thank you, Mara. Thank you, Dr. Ionescu, and thanks to the Young ESPGHAN group, which sounds really dynamic. I wish I was young enough to join you, but this didn't exist when I was training, and seems like something that if I was a trainee, I would be rushing to get into, even if I was just a houseman or resident. Let me try to share my screen, make sure I'm getting this right. Can you see me okay?
Yes, it's perfect.
Okay, good. Yes, we're going to be talking about pediatric polyposis syndromes. I am very lucky in that I've kind of found my dream job of managing mainly these patients. This is about half of the time that I spend at work, is research and clinical stuff relating to this. We're going to go from the genetics of this through the actual endoscopic, and then even beyond that, non-endoscopic management, which I'm going to stress is also very important. I don't have relevant financial disclosures. I'll say that I am European. I am from Malta originally, so that's, I think, nowadays an important disclosure. And let's start off with understanding where polyps and genetics fit together. So we're talking about polyps today, but in the most part, we're going to talk about polyps as being a manifestation of an underlying genetic disorder. And in that respect, obviously, it's important to understand that the gene is the determinant of the clinical presentation, the course, and eventually even cancer risk. So whenever there is no overarching diagnosis of polyposis based on just the polyp, there is an underlying diagnosis of a genetic disorder in most cases, recognized or unrecognized, that then gives us insight on what we should be doing in terms of endoscopy. Now, going down to the endoscopy part of this, endoscopy can be either preventive, where we are essentially looking, counting, measuring, and thereby making decisions in terms of management, or else endoscopy can be therapeutic, especially so in double balloon enteroscopy in PJS. We're going to talk about that. It's important, although most of us have an understanding of what we're talking about when we talk about polyps versus syndromes, we have to understand that polyps by themselves do not make a syndrome. When we talk about a syndrome, a polyposis syndrome, we are talking about something that is defined by a specific pattern, meaning the polyp number, the polyp histology and size, as well as the distribution, very important, the age at presentation, very easily. It's one thing to say I have 2 adenomas in a 10-year-old versus 2 adenomas in a 25-year-old or 30-year-old. It's important to see family history in that respect, and this all can be supported by positive germline testing, but not necessarily. So when we talk about polyposis syndromes, the diagnostic criteria are going to be very syndrome specific, meaning things like adenoma burden beyond sporadic expected for age, or the number and the distribution of hamartomatous polyps completely determines right off the bat what you're going to be thinking about in terms of possible syndromes. At this point, it's very high level, but let's drive down now to the different syndromes that we are talking about. In most cases, when we talk about pediatric polyposis, we are talking about familial adenomatous polyposis, about 1 in 10,000. Juvenile polyposis syndrome, very difficult to actually put your finger on how often this happens, but could be commoner than 1 in 80,000, which is often described. Peutz-Jeghers syndrome, and then rarely P10 hamartoma syndrome. What I want to draw your attention in this slide is, yes, we could be talking about several different genes, the left-hand side of your screen there, APC mutations in FAP, SMAD4, BMPR1As, and JPS, etc. But what we are really talking about are different pathways. So when we look at APC, we're looking at what's called the Wnt-Wingless pathway of APC mutation, and that is a crucial pathway in colon cancer. That is actually the pathway that is involved in at least 80% of sporadic colon cancers in adults. So invariably, when you talk about mutations in APC, you're talking about a high predisposition for cancer. And therefore also, if you think of that polyp type, you're going to be looking at adenomatous, i.e. precancerous polyps. If we look at the other trees, the juvenile polyps, PJS and P10, then you're talking about essentially outbranchings of a group of pathways, but that do not have as strong an association with cancer. And predictably, therefore, when you look at those patients' type of polyps, you're going to be getting reports predominantly, not just, but predominantly of hamartomatous, inflammatory, or juvenile polyps, if you want. So mutation determines syndrome, and syndrome and mutation are really tied into a pathway, and that then goes on to phenotype, which can include cancer. So going into now the cancer risk, following on the previous slide, with FAP, the predominant GI distribution, which is one of the determinants of the syndrome, is going to be colon, of course. And then we talk a lot about upper GI involvement, duodenal, periampullary involvement. That's a bit of a controversial subject in pediatrics. But the bottom line is you have a 100% lifetime risk of colon cancer in FAP if you retain the colon, which of course most of our patients hopefully don't. And that is evolving. That may be evolving in the context of work that's coming out of Japan, but at this point, if you do nothing, it's 100%. That is not so for the other syndromes. PJS carries a high risk cumulatively over life, but nowhere close in terms of colon cancer predisposition. Juvenile polyposis syndrome can be actually down to population level, depending on the genotype. We're not sure, but it certainly is nowhere close to FAP. And the same goes for P10. So then it leads us to, well, obviously then, if I'm suspecting of a syndrome, then I should be doing genetic testing. There's pitfalls here, however. If you think of genetic testing that you have available in the office, in most centers at least, you're going to be offered multi-gene panels. So, cast a nest, take a blood test or a cheek swab, and get these, I'm not sure where we're at, but 50 different genes being tested, including APC, STK, etc., and some other ones that we frankly do not care about. This may seem easy, but it's actually fraught with difficulty, because when you do that, you may be coming across a lot of positives or unknowns, something called variants of unknown significance, VUSs. VUSs, by the way, are the bane of our existence when we get into genetic testing for these patients. Because what a variant of unknown significance really means is you have a result that tells you there is a mutation, probably in an important gene, but you're not told whether it's a pathogenic mutation or not. We just don't know what it does. It could be pathogenic, it could be not. We just don't have enough information. And so what do you do with the patient there? Well, what you have to do is what the slide suggests. You always get genetic counseling when you're thinking about genetic testing. Don't do it by yourself. It is a minefield. In this respect, it's also important to realize that the landscape is changing. Cascade testing is becoming more common. What does cascade testing mean? I'll give you a practical example. So a 40-year-old goes into the hospital and he has colon cancer. They resect the cancer. The cancer goes to pathology. Pathologists stain it for mismatch repair genes, and they find that it is MMR deficient. That makes them think of Lynch syndrome. So they tell the patient that they need to get genetic testing. And lo and behold, that patient winds up having, so this 40-year-old winds up having Lynch syndrome. There is a gene. Cascade testing means that the lab or the company, certainly in the US, the company will, offer free testing to all first-degree relatives. And that may well include one of the patients that you're seeing. So an adolescent, completely asymptomatic, but he comes to your office, he has Lynch syndrome. What do? Do you ignore him? We'll touch on that. But bottom line again, you need genetic counselors to explain the implication of genetic testing. Let's talk about some specific patients. Let's bring out some clinical scenarios. This is Alessio. He's a very cute 6-year-old. He comes in with rectal bleeding. You have a background of normal routine labs, ESR, CRP are normal, CBC is normal. But you hear from mom saying that his dad had kind of a similar history. Dad always complains of bleeding. And interestingly enough, she makes a comment about his aunt having had a stroke and dying at age 28. Quite tragic. You go on to do a colonoscopy in Alessio and you find 3 juvenile polyps. Now, you read that less than 5, you should be okay, right? Not quite. Do you need to follow up on this patient? Well, you certainly need to follow up by looking at the family history. And what you're looking for here is you're lucky when you deal with polyposis in kids. In most cases, except one, and we'll talk about it, in most cases, you're looking at syndromes that are autosomal dominant. So every generation should show you something. Yes, you can have de novo mutations, sometimes up to 20%, but in most cases, the family history is a big clue. In this case, we already heard that Dad has rectal bleeding, but he doesn't want to get a scope. The grandma had colon cancer diagnosed at 55, and interestingly enough, she has frequent nosebleeds. And then there's a history of colon polyps in the great grandpa. On the father's side of the family, we also hear that there was that brain aneurysm stroke patient, as well as her son or daughter who had frequent nosebleeds. These are very important because of juvenile polyposis syndrome. So what do you do with Andrew now? Well, for sure, Andrew has juvenile polyposis syndrome until proved otherwise. He has 3 polyps, which in itself may not be entirely benign, but he also has a family history that is consistent. So we would, at the very least, want to do genetic testing. And specifically here, you are wondering whether this could be SMAD4 mutation, because that correlates with having hereditary hemorrhagic telangiectasia. When we think of the diagnostic criteria for JPS, we think of the JAS criteria, and they're listed here, so I won't go into them individually. Why do we care about SMAD4 more than everything else? Well, because SMAD4 tends to be the bad one of the group. Up to 80% of individuals with JPS will have, of JPS from SMAD4, will have HHT. And in that case, the polyps are actually a minor part of your problem. You're going to be wondering, you're going to be looking for, surveillance-wise, for brain aneurysms, and lung AVMs. And for that, you actually do surveillance and screening, brain MRIs and bubble studies, and a special form of echocardiogram that detects AVMs. Very importantly, however, these patients may also present with liver AVMs and GI angiodysplastic lesions, and those are actually the 2 determinants of mortality in younger individuals with HHT. So recognizing JPS is important, but going on from JPS to understanding that you have a SMAD4 is even more important. What if you have genotype negative patients? I told you that JPS can be SMAD4 or BMPR1A associated, but that's only about 40 to 60%, depending on the study. About half of the patients they will meet criteria for JPS. You will do genetic testing, it will come back negative. What are those patients about? So those are the ones on the right side of your screen. This is from a study published by Shlomi Cohen some years ago, where we were participating in a multi-registry study. These tend to have the genotype negative patients tend to have an earlier presentation. It's not uncommon for these patients to present at 3 to 5 years of age. They tend to have negative family history. In fact, it makes you start thinking maybe this isn't genetics, and that's important. They have very few extraintestinal manifestations. Very few of them wind up getting surgery. And the rate of accretion of polyps is actually low. As a matter of fact, they tend to have more polyps under 10 years of age, but when they reach their teens or late teens, they hardly ever have polyps. So this is a radically different phenotype. And this is important for you because you're going to guide the parents to understand what's coming up later. And here on the left side, you're seeing what the other two match up to. And the BMPR1A and SMAD4 don't differ greatly except for gastric involvement, which is unfortunately also a significant feature of SMAD4. Let's move on to a different patient. This is Jenna. She is 8 years old. She comes to you with, you're thinking, oh, this is probably functional abdominal pain, severe cramping abdominal pain, but then you get the history, bilious vomiting. So you're worried now. She's had a trial of omeprazole, of course, everybody does. She has routine normal labs, and you go ahead, think of malrotation and order a small bowel series. It comes back as negative. Now you're doing family history in every patient after Alessio. So you hear that there is an aunt, it's always the aunts, if you notice, who has had ovarian cancer in her 20s. You go on to doing an endoscopy and colonoscopy in Jenna, and you're wondering, okay, it's negative, it's normal, she doesn't have polyps. What's our next step? Do you need to do any other workup? Well, the giveaway with Jenna was she is so full of freckles, not her facial ones, her lip ones. Those are important, and those are Peutz-Jeghers syndrome until proved otherwise. And if you do go into her family history, what's interesting here is, yes, mom has the same type of mucocutaneous or nail bed freckles. There was a breast cancer family history, as well as an ovarian cancer that you had noticed in the aunt. So this is PJS. With PJS, we basically want to keep in mind the rule of twos. So you're looking for two hits, either two polyps in the small intestine that have a hamartomatous histologic appearance. And although we say hamartoma when we talk about JPS, we say hamartoma when we talk about P10, and we say hamartoma when we talk about Peutz-Jeghers, these hamartomatous histologies are different. In PJS, the one feature that is fairly common or consistent is that you're going to be seeing a smooth muscle core. As a matter of fact, when you excise these polyps, you'll see that they're actually harder to cut through because of that core in some cases. Anyway, the rule of two polyps in the small intestine, one polyp and mucocutaneous freckling and a positive family history, or a positive gene test. Those are diagnostic criteria for PJS. Let's move on to the last clinical vignette here. Gibson, he's still a baby. I don't think he's going to have polyps. This is one that the pediatrician calls you on. And the mom says, you know what? She was told that she needs to bring this up when she sees the pediatrician in the future because she has a family history of colon cancer and she herself has had colectomy when she was 24. All the pediatrician knows is that she had, quote unquote, lots of polyps, no histology, no distribution, just lots of polyps. And he's asking you, okay, well, what do I do? Well, you tell him, get a family history. It turns out that the mom had colectomy from lots of polyps. It also turns out that the maternal grandma had a colectomy at 35 years of age because of polyps. And then if you go further up the family tree, you will find that someone actually died at 45 years of age with colon cancer. This is familial adenomatous polyposis until proved otherwise. This is one of the commoner forms of hereditary polyposis. It's 1 in 10,000. As I said earlier, you're lucky it's autosomal dominant. You should find something in every generation. And the diagnosis is actually any number of colonic adenomas and a positive gene test. So here is one that a positive gene test is necessary to establish the diagnosis unless you have a clear-cut family history here. There are also extraintestinal features you need to be aware of, just like the mucocutaneous freckling in PJS. FAPs can present with usually dental abnormalities, delayed eruption of teeth, congenital hypertrophy of the retinal pigment epithelium, so chirpy, or desmoids anywhere, or osteomas either in the back of the head usually or around the jaw, and these can present early in life. So you want to look for those and factor those in your diagnosis. Suggestive features, as we just went through, is multiple colorectal adenomas. I want you to focus though on the middle part of this slide. There are different phenotypes with FAP. There's what's called the classic phenotype, and there could be an attenuated phenotype. And there is where the genotype actually matters, because the location of the mutation within the APC gene is part of the determinants of the phenotype. For example, we know that one of the commonest mutations, the so-called delta 1309, that tends to give you a more aggressive phenotype, whereas mutations that tend to gravitate towards the 3' end or the 5' end of the APC gene, those tend to give you an attenuated phenotype. What does attenuated mean? It means that everything's kind of delayed by about 10 years. So your average age of going on to colon cancer, which in the FAP is about 35 years of age, now becomes 45 years of age. So genotype matters in phenotype. Now, I wanted to bring this up because I've been telling you all throughout this talk, autosomal dominant, you're lucky. Well, you got to keep your eyes open for this one because this one is not autosomal dominant. And this is very rare. This is constitutional mismatch repair deficiency. We mentioned earlier in cascade testing colon cancer, mismatch repair staining, and Lynch syndrome. That's where that usually comes in. But what if mom and dad both have Lynch syndrome? What if there are carriers for a Lynch syndrome and the child winds up having Lynch from both parents? 1 in 4, of course, so not autosomal dominant. And in this case, you're going to have a very severe phenotype. These kids will present in the first decade of life with brain cancer, hematologic malignancies, as well as colon cancer. So it's important to recognize these patients, and it's very important to have very clear recognition and surveillance set up. Enough said, because this is rare, but it's not all autosomal dominant. And since we are talking about Lynch syndrome, because this is something I'm extremely interested at this point, this is kind of the visual abstract of a paper that's going to be published hopefully by next month. And what we did here is we just looked through the literature on all the reports where Lynch syndrome was diagnosed and had GI manifestations under 21 years of age. Why 21? Because that's the age when we transition to the adults. I realize that in Europe that's going to be early, so this may not be as relevant to you. Anyway, we wound up finding 36 good studies, of which 48 patients were reported, and in 44 patients, the Lynch syndrome diagnosis was associated with colon cancer. Yes, there were some patients who had simultaneous or isolated adenomatous polyps. There was one that had gastric adenocarcinoma and another one that had small bowel cancer. The presentation was not that different from our routine list of complaints. Rectal bleeding for sure, or anemia, but then abdominal pain, change in bowel habit, and some red flags, weight loss would be there. What's important in this study is that 0% of these colon cancers were driven because someone said, you know, there's Lynch syndrome, maybe you should get a colonoscopy. Because honestly, that's not part of the guidelines. What's also tragic and important is that at least almost 70% of these patients presented in an advanced stage of their disease. What's very interesting for me is that unlike adult Lynch syndrome, we saw a switch in the distribution of cancers in this patient. Region of cancer is a very important subtopic actually in colon cancer. And very interestingly, the pediatric Lynch syndrome associated colon cancers tended to be more left-sided than right-sided, which is the opposite of adults. There was also a blunting of the male predisposition within this population. So this is I think that this is a very interesting topic that's going to be relevant in the future. I don't want to linger too much about Lynch syndrome because exactly what I said earlier. Guidelines tell you to ignore these patients. What if we don't ignore them? Well, we're actually opening a can of worms because you're going to be looking at doing genetic testing in an adolescent, in someone where you're told to wait until they're 20 to 24. This age group, the parents can tell you I want genetic testing. The adolescent may not want it. It's very important to have the adolescent buy into this process. Otherwise, what's going to happen is you're going to lose him once he becomes an adult. It's also important to understand, well, what does the genetic test tell us? What if it's positive? Are we automatically going to do colonoscopy? Far from it. You're going to tell them what you don't know more than what you know, and then offer that as a possibility. There's something coming up in the pipeline though too. The most recent studies in adult Lynch syndrome suggest that starting aspirin early in life is going to give you a higher likelihood of preventing colon cancer later on. So in the future, we may be doing this talk in 5 years' time, and we're going to be saying, well, yeah, you do want to know that an adolescent has Lynch syndrome because you're wanting to treat him. Eventually with aspirin, even under the age of 18. So this is an evolving topic within polyposis. Let's move on to the second half of this talk, and that is the endoscopic management of these syndromes. Well, it's important to keep in mind the syndrome and understand your goals. This is a concept that I owe it entirely to Warren Heyer to spell out clearly in terms of what we should be thinking and when. Otherwise, we're all over the place. With familial adenomatous polyposis, you are interested primarily in understanding the polyp burden and the distribution, because that gives you the timing and the type of surgery, which is invariably going to happen, whether it's in pediatric or in adult. A recent study by Colleen Flayhive showed that in the US, the average age of colectomy was actually around 14. There are European studies showing that you guys tend to wait longer, probably safely as well. With PJS, you're interested in finding the polyp size and the polyp distribution in the small intestine. So usually you're going to move away from traditional endoscopy and going into capsule endoscopy, because that's going to inform the need for either enteroscopy or preventive surgery, depending on whether you have it available in your center. Finally, with JPS, your involvement with the polyps is really because they have a risk of bleeding. The risk of cancer is extremely low. But as we said earlier here, the dominant factor is the genotype, because the genotype tells you whether you're going to have upper involvement. So we may want to think of an upper endoscopy sooner rather than later, as well as the involvement with regards to telangiectasia, with regards to HHT. So the risk of vascular accidents. Okay, then moving on. So now we're going to be scoping the patient, and we're going to be removing polyps, presumably. So polypectomy is all about preparation and all about having your skills and understanding what you can and cannot do. Pre-op preparation and endoscopic technique are therefore going to be needed to be established ahead of the actual procedure. When you get into the colon or small intestine for that matter, you're going to want to know a couple of things. The polyp size, vitally important. The polyp shape, of course, that's kind of easy. But then also the surface characteristics of the polyp, so that especially with adenomas or unknown polyps, you can mentally make a picture of what you are likely dealing with. Once you do a polypectomy, you should also be prepared that you're going to want to retrieve a polyp. If they're small polyps, you can probably suction them through the channel. If they're larger polyps, you're looking at going in and out. And in that respect, you may want to think of an overtube when you're doing a colonoscopy, something like what's called Pathfinder. I'm not sure if it's available in Europe, a variable rigidity overtube. When you're actually doing the polypectomy, some principles are very important. How you position the snare, how you position the scope, that you don't have loop. If you have a loop, you don't have control. You assess the stock, make your decision regarding how you're going to remove the polyp based on stock and polyp size. Plan on hemostasis. What if it bleeds? What am I going to do? Do I need to prevent bleeding before I even cut through it? We'll touch on that. And then, as I mentioned, prepare yourself to retrieve the polyp. Hemostasis-wise, you have to think in terms of, if this is a large polyp, should I put a clip on the stalk to avoid bleeding afterwards? Should I inject before I put a clip on? You also want to have mentally an understanding of, how do I avoid thermal injury? Meaning, how do I avoid a burn that winds up being a risk for post-polypectomy electrocautery syndrome? And that happens in two scenarios. You're either over-cauterizing the stalk, in which case you'll see the white area extend to the wall. That's a sign of trouble. Or else you've got a large enough polyp that's actually been touching the other side of the wall of the colon, so that electricity dissipates from there and you cause a bleed on that side. Ironically, when you are faced with a polyp that you cannot completely detach from the surface, meaning you cannot have just the stalk being attached, but there's also a point of contact, you're better off making a maximal point of contact. So the very large polyps, you'll see us deflate the bowel before we actually electrocauterize the stalk. I hope I'm coming across clearly as far as what I'm suggesting there. Post-polypectomy monitoring, it depends on how many polyps, how large the polyps are, whether you want to keep the kid overnight for observation or whether you're just going to give them cautionary notes in terms of when to call you back. So I told you need to know size. Well, size is important, but size is not always very clear. And an important help in that respect is using your equipment. So you can stick out the polypectomy snare, which you know that in most cases is about 2.4, 2.6 millimeters, depending on which type you're using. But anyway, 2.4 is the ballpark. Well, if it's double the size, as in this case here, you know that you're dealing with a 5 millimeter polyp. You can also see that it's a sessile polyp. So now mentally, you know how you're going to take it out, whether it's going to be hot or cold snare. And this is where it matters. So this is a sessile or a pedunculated polyp. If it's very small, it's very straightforward. You're needing either to do cold snare or even just cold biopsy forceps for removing. If you're talking about something that is intermediate in size, 4 to 6 millimeters, it's actually still reasonable to go down the path of cold snare. Between 7 to 10 millimeters, a sessile polyp, you may be wondering, why don't I do hot snare polypectomy? Because of electrocautery. And in that case, we tend to favor more cold snare. If there's bleeding, we'll deal with it. We can either APC the area or put something like a hemostatic agent like Puristat. If you're talking about a lesion that is greater than 10 millimeters, you can do hot snare polypectomy here, but you're going to want to elevate the lesion. So you're going to inject the base, make the lesion more polypoid if you want, and then hot snare the area that is detached. And if this looks more like a complicated sessile polyp, then don't do it by yourself. Let an adult gastroenterologist who has experience with this help you out. Pedunculated polyps, well, it depends all on size again. If the head is less than 20 millimeters, so less than 2 centimeters, and the stalk is less than 1 centimeter, you're very safe to go with a standard hot snare polypectomy. If, on the other hand, the head is greater than 20 or the stalk is greater than 10 millimeters, then you want to do hot snare polypectomy, but you're going to pad this with some prophylaxis for bleeding. Either inject with adrenaline or do a clip, or do both, actually, in our case, our favorite approach. We recently published our experience along with Stanford, removing, I think it was about 470 something polyps via cold snare, with some comparison of hot snare polypectomy in polyposis patients. And bottom line is, cold snare polypectomy tended to be better. We had no delayed bleeding. Yes, there were some intraoperative bleeds that were dealt with, especially with large polyps, with clipping. It was effective. We had a very high resection and tissue retrieval rate, I believe about 95%. There was very low risk of patients coming back after cold snare with any form of bleeding, let alone bleeding requiring intervention. There was none. So this is a very practical, and once you get to learning how to do it, this can be a very practical, useful tool. And for us, it's now certainly the preferred technique for polyps under 10 millimeters in size, which are sessile and sometimes even with pedunculated. I won't linger too much on this slide because I mentioned earlier you need to understand what you're looking at. The other part of what you're looking at isn't just size, it's also the surface characteristics of the polyp, because they can tell you what the polyp histology is in many cases. There's a very big difference between the appearance of an adenoma and a hamartomatous or inflammatory polyp. This just relates to adenoma. So this is a slide that is based on the concept of what's doing what we call a visual biopsy in adults. What you're seeing there is that the darker the color, the more likelier that this is a dysplastic or cancerous lesion. But you also have to be aware of the pit pattern of the polyp. So you're going to be talking about something that looks like punctate versus channels versus branched channels versus an amorphous morphology, which is more likely cancers. You're also going to want to look at the vascular pattern. Again, these are concepts that are good to have. These are concepts very well entrenched in the adult side, and they tell you whether an adenoma can be dysplastic or cancerous. But let's move on to the other area where polyp size assessment and distribution is vitally important, and that is capsule endoscopy in the scope of Peutz-Jeghers syndrome. What you're doing with Peutz-Jeghers syndrome is that by the age of 8, you should have started looking at the small bowel. For sure, obstruction can happen even earlier, but at 8 and above, guidelines tell you should be looking for small intestinal polyps. Now, how do you look? You can go down the path of MRI. Frankly, I think that the literature favors capsule endoscopy, especially for smaller lesions. And positioning the lesions localizing the lesions is probably easier with MRI. But seeing smaller lesions, especially actionable lesions, is going to be easier with video capsule. And that's the area where the video capsule can tell you whether you need to do something like a double balloon enteroscopy or refer to surgery. And double balloon enteroscopy works. This is from a study back in 23 where we just basically looked at the video capsule endoscopy findings in our patients with PJS. But that's not what I want you to focus on. I want you to focus on the right side of the slide. When we compared the 5 years before we introduced double balloon enteroscopy with the 5 years after we introduced double balloon enteroscopy, we had a precipitous drop in the number of surgeries, both overall as well as emergency surgeries. So this is clearly an endoscopic technique that makes a difference in this population. So we talked about genetics going on to endoscopic management, but I want to make sure that you understand genetics, endoscopic management is not the beginning and the end of hereditary polyposis management. It may sound cliche, but this is a disease set that is needing a very patient and family-centered management pattern. What does holistic management in this context look like? And why even do I bring it up? Isn't it just a few polyps, they come out, move on? No, because you're talking to this family and to this patient in terms of, we've discovered your son or daughter has a cancer risk. We're also telling them you're going to need repeated endoscopy and colonoscopy. During those colonoscopies, we're going to remove polyps, and those are high risk. These are these are very different from your routine abdominal pain, come in clinic, do a colonoscopy, nothing going on, or upper endoscopy, nothing going on, move on. These are profoundly life-changing diagnoses for these families. So there are psychologic, psychosocial, and economic comorbidities, certainly in the US, that we have to deal with. And so you tend to really want to form a multidisciplinary core for these patients. We have a coordinator who does wonders with these patients. And then there's me, there's a genetic counselor. As I said earlier, I'm not doing genetic testing. And we also have a psychologist, and I think she does a vital part of this team. We obviously are integrated with the adult gastroenterologists because transition of care is very important in this disease set, as well as surgery, because we do need colectomies in some of our patients. And then after that, we talk about oncology and social work in terms of coping and moving on to the adult side. We recently published our psychologic burden of disease in our patient populations. And not surprisingly, because we've been hearing about this in clinic every time the psychologists talk to these patients, there's a significant decrease in the health-related quality of life in these patients. This reflects in their emotional state, their likelihood of having depression, and their school functioning. So these are important things that you want to be addressing aside from their need for surveillance, whether it be endoscopic and other ones. Well, one of the most important things that comes across every time is illness uncertainty. I don't know what you're talking about, so you really have to explain this well. And I don't know what you're telling me about the future, so you have to be explaining that as well. Very interestingly, this may look like a small number, caregiver burden. 20% of our parents had significant guilt because of the diagnosis that they passed on to their child. 20% actually reflects that it's double that because the other spouse knew where it's coming from. So they were off the hook, if you want, with regards to that. Bottom line, you really have to include psychosocial testing and screening in HPS. So what about the future, aside from dancing robots? There's so much to be talked about in the future. We are looking at biomarker research. We're looking at liquid biopsy, a blood test that gives you your polyp burden. Wouldn't that be great? And then also doing surveillance strategies that are personalized, both in terms of genetics, microbiome, as well as prior endoscopic findings and molecular level targeting. And that goes into the personalized medicine in cancer type thing. But, and that's the whole point of this talk, we need more research. This is a sad slide looking at the number of papers that are written about the subject. And what you're seeing up there, that orange line, those are the number of papers every year through 2024 that we're dealing with polyposis in general. Down there in the green line, that's the number of pediatric polyposis. So guys, if you're listening to this talk, this is so full of opportunities for research. I can't even tell you. And the future is you. So, and in that respect, I would love to see all of you and more of you in the ESPGHAN upcoming meeting, where we're going to have a session on Thursday, the 25th of June. And I'm sure it's going to be exciting and full of new information. Think of joining us. Think of joining the ESPGHAN Polyposis SIG. You are welcome, and we need your input. Think of other opportunities. I'd highlight INSIGHT, the International Society of Gastrointestinal Hereditary Tumors, and the Collaborative Group of the Americas. And with that, advert, if you want, brings me to my last slide. Questions?
Thank you so much for this very interesting talk. So I will start with the first question. Do you think there is a role for the medical treatment in polyposis syndromes?
Yes. I mean, we can have a lecture about that. Depends which syndrome you're talking about. So going back to the pathways, it all goes back to the genetics. And The pathway determines what options you have. So APC, lots of stuff going on or has happened there. Everolimus, celecoxib, not proven to change outcome, but then a difficulty in actually defining, well, what outcome do you want? Are you treating this kid with celecoxib because you're going to avoid colectomy? Not going to happen. Are you going to use two agents together and what? Delay colectomy? Maybe not, maybe, but no, I don't think it's going to happen. Or are you going to use celecoxib and or some other agent and then look at what the Japanese are doing, which is intensive the polyp reduction and plan to keep your colon forever? That is so interesting. I don't have an answer to that. Routine use of nonsteroidals. I I sometimes find myself in a corner where I use it because I want to delay colectomy, unproven, but it seems to work. But again, you need to explain that to the parents. Moving on, the other three forms, as I said, these are outbranchings of similar pathways, and so in that population, rapamycin may have some exciting opportunities. Nothing proven so far. Again, we need research, guys. We need you. We need you to help us. I hope that answers the question poorly.
Thank you so much. So we started having some questions from our participants. So from Emily, she asked, are there any registries for pediatric polyposis syndrome that we could contribute to?
It depends on the country. I'm very much aware of the UK because that's who I collaborate the most, and obviously there the giant in the room is St. Mark's Registry. And yes, linking out to these registries is important. Italy also features very prominently, in Belgium and the Netherlands. I read about registries there, and these registries tend to take all comers. They will take adult and pediatric. As a matter of fact, these registries publish data that is so rich and interesting, but it doesn't have pediatric breakdown. So that was one of the problems we had when we were looking at the Lynch syndrome. So yes, there are registries. Look at your specific countries. Look at whether you can plug your patients into them because they really take over care and surveillance, especially the non-endoscopic part, and they provide a great service. As a matter of fact, the United States kind of suffers from this because we're so interinstitutionally competitive that there are no like regional registries which would actually benefit patients.
Thank you very much. From Helga, another question. Up to what age can I wait to perform a colectomy in a patient who is genetically positive for FAP?
Yeah, so the gene tells you that the disease is there, but it doesn't tell you when. You have to do colectomy. Colectomy is determined by several factors. One, and of course, the driver is your risk of cancer. Your risk of cancer, in turn, is going to be determined by the size and the number of polyps. You go into a colon and you find it carpeted by 5 millimeter polyps. I know that each individual 5 millimeter polyp has a very low risk of colon cancer, but you are talking about hundreds to thousands. So that's a reasonable time. You go into a colon and you find a hundred polyps, but they're greater than 10 millimeters, greater than 15 millimeters. That too, every one of those polyps has a high risk. So you have to devise an idea of polyp burden and risk. There are other factors that play into that. Is the child or young adult ready for it? So maturation and patient buy-in is very important. What kind of surgery are you arguing for? Are you going to do ileorectal or ileal pouch anal anastomosis? And what did the family history tell you? Does he have a parent or a grandparent who died in their 20s? Because in that case, I would be going earlier rather than later for colectomy. So it's not a perfect answer, but because it's a complex decision.
Thank you. How would you manage patients with clinically polyposis syndrome and genetically negative? How often do you repeat the scope?
Yeah, so it depends on the syndrome, right? So we have a ton of GPS patients who have mutation negative. And for now, you just have to tell parents, you know, because we don't know any better, because this is defined by the phenotype, not the genotype. JPS is phenotype driven, not genotype. We know you don't have SMAD4, we know you don't have BMPR1A, but we don't know that you have nothing. So we're going to be treating you just like everyone else. Now, if I do a scope, and happens very often, in a 15-year-old, and there's no polyps in their colon, I'm going to be more daring and say we can wait for 2 years, even 3 years before we rescope. But I'm not going to get to a point where I say, you know, you've not had any polyps in your last 2 colonoscopies, so you're off the hook. Because the JPS phenotype does not necessarily mean the cancer phenotype. In fact, it probably doesn't. Just by virtue of you having a polyp, which is hamartoma, and you having a risk of cancer, this doesn't need to transition into this. This and this can be independent. I hope I'm making that concept clear. So yes, you can you have to Now, there's also something to be said about genotype negative FAPs. A classic, someone who comes to you with congenital hypertrophy of the retinal pigment epithelium. If it's unilateral, forget it, there's nothing. Just make sure someone looked at the other side properly. But if you've got a good exam and it is unilateral, again, disregard. 10% of the population may have that. If you have it on both sides, that's actually very significant for the likelihood of FAP. And even if you do have a negative gene test, you probably want to have at least a baseline colonoscopy and decide from there.
Super, thank you. From Anne-Marie, thank you for this really useful talk. In your expert opinion, what are the common pitfalls in the diagnosis and surveillance plans of patients with polyposis, e.g. misdiagnosis and wrong advice?
Yeah, I think that's a really difficult question. Thanks, Anne-Marie. Um, there's so many pitfalls here. For sure, one of the commonest pitfalls actually is doing the genetic testing by yourself. There are lawsuits out there, there are bad outcomes, there is bad advice. It is literally you are prancing in a minefield if you do genetic testing because the rep told you you can do it, like sometimes happens here. So that's the first one. Then the next one is actually being over aggressive. So if you go in there and you find a polyp burden that clearly warrants colectomy, you probably want to reach out to someone who is expert in the field and say, is this real? Is this not? What you don't want to do is try to remove them yourselves without having a clear plan. Is it realistic that you're going to remove 300 polyps in the next, what, 2 years? Like, what are you actually selling and for what? In FAP, that would be sacrilegious. In JPS, who knows? But again, don't be over aggressive, know your limitations, and give realistic plans to patients. I think that those are the two main pitfalls.
Thank you very much. We still have one more minute. What is the maximum safe number of polyps that can be removed during a single endoscopic session? Should all resected polyps be retrieved for histopathological examination, particularly when a large number, like let's say around 40, are removed?
Yeah. And we can go beyond 11 if you guys, if Zoom allows us, I guess. What's the maximum amount? Well, there's no guideline to tell you what. I mean, it depends what you want to do. I've certainly had cases where I've removed up to 135 or 140 polyps. But again, I mean, you can have a large polyp that's harder to remove than a dozen small polyps. I mean, cold snare polypectomy, those 500 patients we described, the average duration of the colonoscopy was 52 minutes. So it wasn't like a dramatically altered scenario. Yeah, I mean, significantly increased, but not out of this world. So the maximum number depends on your expertise and depends on the polyp phenotype. And I'm sorry, what was the second part of that question? Because that was also very
Should
important.
all resected polyps be retrieved for
Yes.
histopathological examination?
Yes. I mean, obviously, in the perfect world, there is no way I'd be telling you, no, you can leave those there. Because for sure, in something like FAP, even a polyp that is under 1 centimeter in size has a meaningful risk of colon cancer. So you should try to retrieve those polyps. Um, what's actually harder is not just retrieving them, because a lot of times you can suction these polyps out of the scope. It's actually having enough coordination with your tech so that she or he knows where the polyp that you just suctioned out came from. Because aside from knowing what the histology is, low grade, high grade dysplasia, it's also understanding where this dysplastic, or even for that matter, cancerous lesion came from. Otherwise, you're flying blind. So yes, retrieving polyps is an important principle. Do I always manage? No. But I can't tell you that it's not important. It is.
Yes, and one other question that I think is connected: what is the approach for dysplasia found with FAP patients?
Yes. So high-grade dysplasia is irrespective of the number of polyps, or irrespective of the type of polyps, going to determine your speed of going on, your urgency, if you want, of going on to colectomy. In practice, what does that mean? You go in there, you find 30 polyps, they're fairly unremarkable. You take the larger ones of the greater than 5 millimeters. That's what we tend to do. And one of them comes up as being high-grade dysplasia. Well, then that scenario means that you may have missed lesions which are closer to that size and harbor high-grade dysplasia. You are clearly looking at a kid who you know is eventually going to need colectomy. Now you have an accelerant, if you want, to that process. So yes, high-grade dysplasia is something that drives colectomy sooner.
And Adriana is asking if you have any experience in the use of sirolimus for multiple polyposis.
Yeah, so we have used sirolimus in JPS cases where the polyp burden was very high, and I know that there's literature out there suggesting the use of sirolimus in patients who have juvenile polyposis of infancy. I didn't talk about it because it's so rare, but this is a scenario where you have a deletion that involves both the BMPR1A locus as well as the P10 locus on chromosome 10. So you essentially have a deletion of two polyposis genes, and predictably, those patients present very early with quite aggressive polyposis, and that's where a paper by, I think, Rojas and Thompson several years back showed some benefit. So that's a scenario you would use them in.
I read some articles, and many of them are in mice. Using
there is work in mice, and honestly, when your back is against the wall and you have a JPS patient, especially ones with BMPR1A with a huge polyp burden in their colon. I have a 6-year-old like that, and I'm always being threatened by anemia. So we used sirolimus, and we saw some improvement. Can't say it changed the world. I also used it in SMAD4s who have gastric involvement, to the point where we're thinking gastrectomy, and we were not impressed by the results, and we were limited in many cases by hypertriglyceridemia.
And we have another question from India. The last question: in my practice, many patients clinically suspected to have polyposis don't have any identifiable mutation. What is the ideal protocol for such patients? There was a bit of a similar question.
Yes, can we ask, are these juvenile polyposis syndrome patients, or are these more like FAP or PJS?
Dibiendu, if you can answer.
Let me make an assumption then. So mutation negative JPS, the guidelines at this point do not help you very much. You have to treat the same as ones who have mutation positive. Down that path, you don't have to worry about arteriovenous malformation because they don't have SMAD4. However, you're still going to be doing routine colonoscopy surveillance for cancer risk, not just for polyps. Because in these patients, you know that about 15% of patients will have colon cancer by the age of 30 something, 30% by the age of 60. So surveillance is important. What to do with APCs that have negative genotype testing? That should happen very rarely. So you may want to go back and see what kind of test is being done. But they do exist. And in that case, you actually have to be thinking a bit harder. Are you sure you're dealing with that diagnosis? Could you be dealing with MUTYH, for example? Could you be dealing with Lynch? Or could you be dealing with something like CMMRD? Depending on the age group and the phenotype, you have to think a bit harder. With PJS, it does happen sometimes that you have a negative genotype, very often when there's a hazy family history and some mucocutaneous abnormalities. I tend to be, I tend to treat the same because really your mainstay of surveillance is capsule endoscopy. And in those cases, I explain to the parents the difficulty with the diagnosis at this age and offer continued video capsule endoscopy surveillance.
Super. Thank you so much. People are also looking forward to the polyp session in Lille.
I'm definitely going to be there and I hope to see you all. And if you guys want to reach out with questions, I'm available and do some research on polyposis, guys. We need younger people.
Thank you so much for this. We also we are a bit late also, so I think that we can stop for now, but we can keep the questions for Lille. Thank you so much.
Are there more questions?
Yes, I think there are two more questions. If you want me, I can.
I've just opened the chat. Sorry. So there's India there. Thanks for the. Should capsule endoscopy be routinely performed in patients with familial? Oh, no, absolutely not. No, there is no role for video capsule endoscopy in the routine management of FAP. If we're gonna talk about controversial subjects with FAP, we're gonna be talking about upper endoscopy, not capsule endoscopy. If you do capsule endoscopy in these patients, trust me, you're gonna get a headache because you're gonna see some lesion here, some lesion there. They never mean anything if they're past the duodenum. Certainly in the pediatric population. In adults, yes, maybe there's a risk of, not maybe, there is a risk of small intestinal adenocarcinoma. So you can talk about that, but that's not part of remotely pediatric guidelines. Should capsule endoscopy be performed in a patient with juvenile polyposis syndrome after 2 prior surgeries for intussusception caused by polyps? I mean, if I have a history of intussusception caused by polyps, if they're small intestinal, I would certainly question whether I'm dealing with JPS or PJS, Peutz-Jeghers versus juvenile polyposis. And I have a very low threshold to doing video capsule endoscopy. So those are the 2 things that come to mind. Risk of CRC in inflammatory polyposis and ulcerative colitis. That is such a difficult subject because pseudo polyps are not really polyps, but we do know that ulcerative colitis, or for that matter, any form of inflammatory colitis, given a long enough time, given enough severity, will entail a risk of colon cancer, usually after 8 to 10 years of disease. In terms of pediatric specific data, I don't think that exists. And especially then you're really getting into the definition of pediatrics, because obviously when you're looking at patients who you're following up to the age of 14, 16, it's not going to be easy for you to find patients diagnosed for 10 years. But for groups like in the US, where you're watching them until 21, you're going to see a significant amount. So that is a growing concern in our population. There is a patient who has PJS 12 years ago. She has duodenal polyp under size 5 and low-grade dysplasia. Low-grade dysplasia. Have not this, yes. Duodenal polyp under size 5 and low-grade dysplasia. Well, And that goes into what the guidelines say, because the guidelines actually tell you to do upper endoscopy and colonoscopy routinely to look for polyps because of risk of bleeding. There is a risk of malignancy tending to be with older ages. Your small bowel capsule and your surveillance of small intestine being video capsule is the intussusception risk. It's not the histology. So when you're doing these surveillance, in practice, what this translates into, when you're doing surveillance for these patients, you're going to want to do upper endoscopy and colonoscopy, just looking for polyps. And you can actually either drop the capsule at the same time or have them ingest the capsule about 2 hours before the procedure. That way, the poor kid doesn't have to go through multiple cleanouts, get all his surveillance done in one day. I think I hope that answers it. Under 5 millimeters with an isolated gastric adenoma, I don't think guidelines reflect that even in adults. So my practice usually has been in that kind of scenario with smaller lesions, rescope in 3 to 5 years.
Thank you very much. It was a super interesting talk. Can't wait to seeing you in Lille.
Thank you. Yes, hope to see you guys and keep up the good work. Fantastic group. So,
thank you so much again for accepting
you.
our invitation. And thank all the participants for all these great questions. See you next month.
Bye.
Goodbye. Bye-bye.